Welcome back to the deep dive. Today we're tackling a really important topic, compartment syndrome.
Definitely important.
We've gathered our notes, aiming to pull out the key info, especially useful if you're prepping for exams like the MSRA or just need a solid understanding.
Absolutely. It's all about getting the essentials clear and memorable.
So let's start right at the beginning. What is compartment syndrome, fundamentally?
Okay, so basically it's when the pressure inside one of your body's compartments, these closed-off anatomical spaces, gets too high.
Right.
And that high pressure starts to squeeze everything inside, mainly the blood vessels and nerves. This limits blood flow, and that can lead to tissue damage if it's not dealt with quickly.
Okay, so high pressure, restricted blood flow, potential damage. And when we say compartments, we're mostly thinking limbs, arms, legs.
Yeah, exactly. The limbs are the most common places. Think lower leg, forearm, those are the classics. But it's worth remembering, it can happen elsewhere. Abdomen, gluteal region, less frequent, but possible. The key thing is that pressure buildup in a confined space affecting the nerves and vessels there.
Got it. And our notes mention two main types, acute and chronic.
That's right. Acute is the one that comes on fast, usually after some kind of trauma like a bad break or a crush injury. It's a real emergency.
Okay.
Chronic is different. It tends to be related to exercise, comes on with activity, gets better with rest, then comes back again if you do the same activity. More of a recurring issue.
Right. So to maybe help picture it, like imagine a container that's totally sealed and you just keep shoving more stuff into it. The pressure is just going to build and build, eventually squeezing whatever's inside, stopping things from flowing properly.
That's a really good analogy. Yeah, it nails that idea of rising pressure in a fixed space, squeezing the vital structures. Perfect memory hook.
Okay, cool. So let's dig into the why, the etiology. What actually causes this pressure to shoot up?
Well, like we said, it's that pressure rise. And that can happen for a few main reasons. Trauma is a big one, other injuries, or sometimes underlying medical conditions.
So traumatic causes first.
Yeah. Fractures are probably the most common trigger, especially lower leg, like the tibia and forearm bones.
Right.
And that includes fractures that have been fixed internally, with plates and screws, or ones that get infected. Crush injuries are another major cause. Severe bruises or contusions. Even burns can do it by causing massive swelling.
Okay, makes sense. What about situations where there isn't an obvious big injury, non-traumatic causes?
There are quite a few, actually. Really intense muscle overuse, thinking endurance athletes pushing hard. Prolonged compression from the outside is another one, like a cast or bandage that's way too tight.
Yeah.
Then you've got things happening after surgery, sometimes vascular issues, like ischemia reperfusion. That's when blood flow returns to an area after it's been cut off for a while, and that itself can cause swelling. Also, internal bleeding or hemorrhage within the compartment, or a rare but serious DVT complication called phlegmasia carulia-dolens.
Wow, okay.
And we can sometimes cause it ourselves. Unfortunately, iatrogenic causes like intramuscular injections or trying to puncture a vessel, especially if the patient is on anticoagulants, blood thinners.
Right.
And even just significant muscle growth, like in bodybuilders or athletes, can sometimes lead to chronic compartment syndrome.
So quite a range of causes, which naturally leads to asking, who's most likely to get this? What are the main risk factors?
They really follow directly from the causes, as you'd expect. So anyone with those major traumas, fractures, crush injuries, they're definitely at higher risk.
Makes sense.
People doing really intense physical activity, prone to muscle overuse, especially for the chronic type. Having prolonged compression, like we mentioned, with tight casts. And then certain medical conditions that make you more likely to swell up or bleed easily, like coagulation disorders.
Okay, so the causes and risks are pretty well linked. We've got the what and the why. How about the how? The pathophysiology.
Yeah.
What's the actual step-by-step process leading to the damage?
Right. It's like a domino effect, really. It starts with that increased pressure inside the compartment. That pressure physically squeezes the tissues, the muscles, the nerves, and importantly, the blood vessels. This squeezing impairs the blood flow.
Okay.
Less blood flow means less oxygen gets to the tissues. That's tissue ischemia. And if that ischemia goes on for too long, the tissue starts to die. That's necrosis. And that can lead to permanent damage.
And it's not just the arteries getting squeezed straight away, is it? I remember reading something about the veins.
That's a really key point, actually. Often the veins, which have lower pressure, get compressed first. When venous outflow is reduced, it leads to congestion, fluid buildup, and reduced flow through the tiny capillaries. This just makes the swelling and ischemia worse, and the pressure keeps climbing. It becomes a vicious cycle. And eventually, if that pressure gets high enough, say higher than the patient's systolic blood pressure, it can actually stop arterial blood from even getting into the compartment. That's obviously a very bad situation.
Definitely. So if someone comes in with symptoms that look like this, what else could be going on? What are the key differential diagnoses we need to keep in mind?
Yeah, ruling out other things is crucial. A deep vein thrombosis, a DVT, can cause leg pain and swelling.
Okay.
Acute arterial occlusion, a sudden blockage of an artery, is another emergency that can look similar. Cellulitis, which is a skin infection, can cause redness, swelling, and pain. Sometimes severe sprains or muscle tears might mimic the pain. For the lower leg specifically, you'd think about medial tibial stress syndrome, shin splints, or even stress fractures, although the pain pattern is usually different.
Right.
And occasionally rare vascular problems like a popliteal artery aneurysm behind the knee or arterial dissection. So quite a list to consider.
Definitely need to keep those in mind.
Okay.
Let's zoom out a bit. Epidemiology. How common is this, especially thinking about the UK?
Well, exact UK numbers are a bit hard to pin down, but we know it happens across all ages. It is, however, more common in certain groups.
Like who?
People involved in high-impact sports, trauma victims, obviously, and sometimes post-surgery patients. For the acute type, estimates suggest around 7 cases per 100,000 males per year, and maybe closer to 1 per 100,000 females.
So quite a difference there between males and females.
Yeah, a lot of acute cases are linked to trauma, especially tibial shaft fractures, and it does tend to affect males under 35 more often.
Why is that?
It's thought to be partly due to generally larger muscle mass in young men and maybe a higher incidence of the types of trauma that cause it.
Okay.
There are also links to things like hemophilia, other bleeding disorders, and even some childhood conditions like pediatric leukemia.
Interesting.
And a really important point, some cases of acute compartment syndrome actually happen without a clear major trauma, and these non-fracture cases can sometimes be trickier, maybe leading to delays in diagnosis and potentially worse outcomes.
That's definitely something to be aware of. Okay, now for arguably the most critical part, spotting it. What are the clinical features? The signs, the symptoms, the red flags?
This is where being vigilant is key. Early recognition saves limbs, essentially. The absolute classic symptom is severe pain.
Right.
And crucially, it's pain that seems way out of proportion to what you'd expect from the injury you can see.
Okay, pain out of proportion. What else?
Progressive swelling is common, and the affected area feels really tense, hard, like wood sometimes. Patients often describe a feeling of intense pressure or tightness. Decreased sensation, pins and needles, numbness, what we call paresthesia, is a really important early sign of nerve involvement. Muscle weakness in that compartment can also develop.
And pulses.
Pulses can be diminished or absent, but often that's a later sign. Relying on pulses alone can be dangerous because significant damage can occur before the pulses disappear.
Got it. So don't wait for absent pulses.
Exactly. In really severe late cases, you might see the limb looking pale pallor or even bluish, which is cyanosis.
And this is where the famous 6Ps mnemonic comes in handy.
Absolutely. It's a great memory aid.
Yeah.
So the 6Ps are pain, the out of proportion kind. Coagulothermia, the limb feels cool compared to the other side.
Right.
Paresthesia, that numbness or tingling, a key early sign. Paralysis, muscle weakness, or inability to move the affected muscles. Pulselessness, weakened or absent pulses, but remember, often late. And pallor, the paleness, also often late.
Pain, poikilothermia, paresthesia, paralysis, pulselessness, pallor.
Got it. And that feeling of pressure the patient describes is important too.
Very important. Listen to the patient if they say it feels incredibly tight or pressured inside.
Okay. And where do we typically see this happening most often? Specific compartments?
Yeah, in the leg, the anterior compartment, that's the front shin area, and the deep posterior compartment at the back of the calf are common culprits.
Right.
In the arm, it's often the volar compartment of the forearm, the palm side. Especially after certain fractures, like we said, tibial fractures for the leg, or supracondylar fractures near the elbow for the arm. And how quickly does this usually develop after an injury?
Typically within the first 48 hours. So that post-injury period needs really close observation. And remember, you need a high index of suspicion, even in patients who can't tell you their symptoms, like unconscious trauma patients. You have to rely on the physical signs, then the tenseness, the swelling.
Okay. And just to reiterate those later signs again.
Yeah, later on you'll see more obvious signs of tissue ischemia. The limb might be cool, pale, maybe cyanotic, and capillary refill will be sluggish or absent. Paresthesia, though, that's often the first clue something's wrong with the
Right.
nerves.
Paresthesia is key early on. So we suspect it based on these features. How do we actually confirm the diagnosis? What investigations are needed?
The definitive test, the gold standard, is measuring the pressure inside the compartment directly.
How's that done?
It's an invasive procedure. You insert a special needle connected to a pressure transducer directly into the muscle compartment you're worried about. This gives you an objective pressure reading.
Okay. Are there non-invasive ways?
People are working on them, things like near-infrared spectroscopy or ultrasound, but currently, direct pressure measurement is still the most reliable way to confirm it.
Got it. What about imaging? X-rays.
Definitely do x-rays. You need to see if there's an underlying fracture causing the problem. Sometimes CT or MRI scans can be helpful, especially if the diagnosis is unclear or you're looking for other causes like a hematoma, but they shouldn't delay treatment if compartment syndrome is strongly suspected clinically.
Okay. Any blood tests or other investigations?
Yes, checking serum creatine kinase, or CK levels, is important. High levels indicate muscle damage or necrosis.
Right.
Urine myoglobin can also be checked for the same reason muscle breakdown products ending up in the urine. And if you suspect significant muscle breakdown, known as rhabdomyolysis, you absolutely need to check kidney function tests, urine myoglobin again, and do a urinalysis, because rhabdo can cause serious kidney injury.
Okay. And maybe an ultrasound?
Yeah, an ultrasound with Doppler can be useful to rule out other things on our differential list, like a DVT or an arterial occlusion.
Makes sense. So let's say the diagnosis is confirmed or even highly suspected based on clinical signs and maybe initial pressure readings. What's the management? What needs to happen immediately?
Time is absolutely critical here. The main goal is to relieve that pressure fast. The definitive treatment is surgery of fasciotomy.
Okay, explain fasciotomy.
It's where a surgeon makes long incisions through the skin and, crucially, through the fascia, which is that tough connective tissue layer enclosing the muscle compartments. Cutting the fascia allows the swollen muscle to bulge out, immediately releasing the pressure inside.
Right, opening up the compartment. What about before surgery?
Immediately, you need to remove anything that could be constricting the limb. Cut off all bandages, dressings, split casts right down to the skin completely. Elevating the limb used to be recommended, but now it's generally advised to keep the limb at the level of the heart, as elevation might worsen arterial inflow if pressure is very high.
Okay, good point. What else?
Pain relief is important, so appropriate analgesia, 4V fluids are usually given as well.
And what if, sadly, some muscle damage has already occurred by the time they get to surgery?
If there's clearly dead necrotic muscle found during the fasciotomy, the surgeon will need to remove that tissue that's called debridement. And in the worst case scenarios, if the limb damage is too extensive and irreversible, amputation might be the only option to save the patient's life or manage infection.
A grim possibility. After the fasciotomy surgery, what's the recovery and ongoing care like?
Post-op care is really intensive. The fasciotomy wounds are often large and initially left open to allow swelling to subside.
Okay.
This means meticulous wound care is essential to prevent infection, which is a big risk. Often, delayed primary closure or skin grafting is needed a few days later to close the wounds once the swelling has gone down. And then rehabilitation is key. Physical therapy, sometimes occupational therapy, to regain strength, movement, and function in the limb. Plus, you still need to manage the original injury, like the fracture.
Right. Address the underlying cause. So thinking long-term, what's the prognosis? What's the outlook for someone who's had compartment syndrome?
It really varies hugely. It depends heavily on how severe it was, how quickly it was diagnosed and treated, and if there were other injuries involved.
Okay.
Nerve injury can sometimes recover, at least partially, over weeks or months with therapy, but it might not be complete. Muscle tissue that has died due to lack of blood flow, infarcted muscle, that damage is permanent. It doesn't regenerate.
So the timing of that fasciotomy is everything.
Absolutely everything. Early surgery before irreversible damage sets in leads to much better functional outcomes. Delay significantly increases the risk of permanent damage and disability.
Which leads us to complications. What are the risks if treatment is delayed or if it was a particularly bad case?
The complications can be really serious and life-changing. Permanent nerve damage can lead to chronic pain, numbness, or weakness. Permanent muscle damage leads to loss of function. There's the risk of infection in the damaged tissue or the surgical wounds. Delayed wound healing is common. Some patients might need further reconstructive surgery down the line, and as we mentioned, amputation is a potential outcome in severe or neglected cases.
How quickly does that irreversible damage start?
Significant muscle necrosis can start to occur after about 4 to 6 hours of severe ischemia, and it's often considered largely irreversible by around 8 to 12 hours. Nerves are perhaps a little more resilient initially, but they also suffer permanent damage with prolonged ischemia.
So a very narrow window.
Extremely narrow, and when that muscle dies and is replaced by scar tissue or fibrosis, it contracts and shortens. This can lead to what's called an ischemic contracture. The classic example is Volkmann's ischemic contracture in the forearm, leading to a fixed claw-like hand deformity.
Wow.
One other important point, people who've had chronic exertional compartment syndrome are actually at a higher risk of developing acute compartment syndrome later on, so they need to be educated about the warning signs.
That's crucial for patient education.
Mm.
Okay, so let's try and crystallize this. What are the absolute key takeaways from this deep dive? The must-remember points about compartment syndrome.
Number 1, early recognition is vital. Be suspicious. Think about it, especially with trauma. Remember those 6 Ps, but focus on pain out of proportion and paresthesia as early critical signs.
Right. Pain in pins and needles.
Number 2, if you suspect it, act fast. Remove constrictions immediately. Get an urgent surgical opinion. Prompt intervention, usually fasciotomy, is the cornerstone of treatment.
Urgency is key.
And number 3, understand the consequences of delay. Irreversible muscle and nerve damage happens within hours, leading to potentially devastating long-term complications and functional loss.
Pain out of proportion, paresthesia, act fast with fasciotomy, delay causes permanent damage.
Got it.
Exactly. Keep those points front and center.
It really does hammer home just how time-sensitive this condition is. A really powerful reminder of why swift diagnosis and action are so crucial in medicine. Thank you so much for breaking that down for us. My pleasure. It's a critical topic.
And for everyone listening, if you're looking for more great resources, especially for MSRA prep, definitely check out PassThemSRA.com and also FreeMSRA.com. Lots of valuable stuff there. Thanks again for joining us on the Deep Dive.